Okay. Okay. Can everyone see that? It's like a regular slideshow.
Yes.
Okay. Perfect. Okay. Great. Well, welcome everyone. I am the clinical pharmacist at the University of Utah Neurology Clinic. I work with the headache patients as well as the other specialties that come through our clinic. And I'm excited to just talk with you guys tonight. I did prepare a few slides just on some new medications. Some of them, you guys may have heard about. Some of them are hitting us pretty hard with commercials these days. But for those of you who aren't familiar, there'll be a good overview and then lots of time to discuss any sort of medication questions you have, and hopefully I can help you with anything. So it's important just to make sure that we understand what diagnostic criteria is used with regard to migraine medications, because, and we'll talk about access to medications at the end, but insurance companies look specifically to the diagnosis and the diagnostic criteria when they're going to cover new medications, or sometimes when they're looking for ways to not cover medications. So when we're looking at migraine, it's not just a headache, but the severe headache. So the severity, they look at how it distinguishes from a common headache. Quantity of events like per month is important. How that changes once you're on a medication is important. So we're looking at all of those things. And as you may know, we're doing both preventive and abortive treatment to take your migraine and go from both angles. Preventive treatments were largely, and I would say largely the vast majority of them were just other medications that were found to be helpful for migraine and preventing migraine. And we just used them what's known as off-label. They didn't have a specific FDA indication for migraine, but we used them anyways. And that really changed just recently with our CGRP antagonists in 2018. Abortive treatment, the mainstays are still triptans, which cannot be used in certain populations, like patients who have had a stroke or a heart attack, and they're not effective or efficacious, are not tolerated by all patients. So we had a few new abortive treatments come through in just the past year, which has been really exciting. So CGRP is, since 2018 has been a really exciting area for research. We have those preventive treatments that were approved in 2018, and we've had a new preventive treatment approved as well as abortive treatments that work on CGRP. So it's important to know where this kind of plays in and how it plays a role and how targeting it can be helpful in many ways for migraine. CGRP stands for calcitonin gene-related peptide. It's found mostly in the central and peripheral nervous system, where it plays a role in pain modulation, sensitization, and perception. That's obviously very important to us in treating migraine. It is also a potent vasodilator and has biologic effects on the different muscles, so cardiac, skeletal, and smooth muscle, in the endocrine system and the GI tract. Luckily, that has not played much of a role with regard to when we antagonize it. It doesn't seem to cause any issues with these other body systems, but it's certainly something that they looked at and is continued to monitor. If you take a look at this graphic, we can see just kind of the few ways that CGRP specifically plays a role in pain and how antagonizing it is helpful for pain. So first we have that it can block neurogenic inflammation. We know that inflammation plays a big role in pain. So by blocking CGRP, we are blocking that inflammation and targeting pain that way. We know that migraine and vasculature is really highly connected. So if we decrease that blood flow, then we're helping with migraine specifically. And in inhibition of pain transmission. So we found that at the junction of the nerve cell. If we block CGRP there, we're inhibiting that pain transmission. So it's not just in one way that we're targeting CGRP and having a good effect on migraine, it's in multiple different ways. So previously we have these 3 CGRP agents, which you guys may be familiar with. Aimovig, Ubravi, and Emgality are their brand names. These are all subcutaneous, so under the skin, at-home injectables, so you do them at home. Generally, these agents are considered similar in efficacy. About 40% of chronic migraine patients experienced a 50% or greater reduction in monthly migraine days, so that's really good. Adverse effects, even since they've been out for a couple years, adverse effects still are pretty minimal. Injection site reactions are by far the most common reaction for each of these agents. Arenumab or Aimovig specifically does carry a label warning because it can cause constipation and new and worsened hypertension or high blood pressure. So that is something to keep in mind for that particular agent, although it's rare. These, like I mentioned, are the first medications that were developed specifically for the prevention of migraine. And so that was really exciting, and their really high efficacy made it doubly exciting when these came out in 2018. Emgality shares also an approval for cluster headache prevention, and that is the only one that does that. It has a little bit of a different dosing strategy for the cluster headache. But new in the past year, we have one more agent for migraine prevention that's brand name Vyepti, and 2 that target CGRP but are for abortive treatment, and that's Nurtech and Ubravi. So Eptonismab is different from the other 3 that we already have approved because it's an IV formulation. It's given via an intravenous infusion every 3 months, and there is a lower dose and a higher dose. It is an antagonist at the ligand, so that is similar to the Ubravi and the Emgality, but differs from the Aimovig. The adverse effects with this are again minimal and similar to placebo, but there is the risk of hypersensitivity reactions, which is not uncommon in infusions or IV medications. Reactions occurred in only 1% of patients on the 100 milligram dose and 2% of patients on the higher dose. But it did include angioedema, which is a really severe swelling of the mouth that is not going to respond to like your normal Benadryl. It's a severe and emergent situation. In addition to more common and mild reactions like hives, which scientific name is urticaria, facial flushing and rash. Again, these were most often not serious, but because they did happen in 1 to 2% of patients, it is important to recognize that. And that's why Vyepti does have to be given in like an infusion room, where if you do have a reaction, someone can be there with whatever you need to treat. So Vyepti is new, and none of these agents were compared directly with each other. So it's really hard to say, but Eptonismab, the Vyepti, may have a higher response rate than the subcutaneous options. Now, while you can't compare them apples to apples, you do have to take a look at the studies that were performed because they did have often the same parameters that they were looking at. And almost 60% of patients, or about 60% of patients, experienced that 50% or greater reduction in their monthly migraine days, which may, was higher than was seen in the trials for the subcutaneous options by a little bit. However, we won't know for sure if it's better unless they did do a trial where they actually compared someone who was on the Vyepti versus someone who was on, say, Emgality, and actually compared over time in a controlled way who had more migraines and who didn't, and who had a greater decrease in migraines. And so now we have these two agents that are for abortive treatment, the Ubravi and the Nurtech. They are pretty similar in dosing strategy. So the Ubravi has more than one dose that you can take, and you can repeat that one after 2 hours. The Nurtec, though, is just a one pill once situation. You don't repeat until the next day, so 24 hours later. These had very few side effects. Nausea was the most often seen, but very rarely, and a little bit of tiredness or somnolence with the Ubrelvy. Both of these medications, which does differ from our preventive options, both of these abortive treatments can interact with certain other drugs, which oftentimes will result in recommendations for dose adjustments, extending how long you take in between doses, or avoiding combinations of drugs altogether. So this is important if you were to say like get a sample from your headache provider. We don't have samples for these at the U, but a lot of providers may have samples of these, and you want to make sure that the doctor has looked at your medication list to make sure that you don't have any interactions, because that's not going to go through the computer like a prescription would to flag any of those interactions. With regard to how effective these are, patients who took it, about 20% with each of these, they're considered equally effective. About 20% of patients were completely pain-free at 2 hours. So that seems like maybe it's a low number, but they were required to say how many patients were completely pain-free, and that is 1/5 of patients, which is still a good number, and far more patients had some degree of pain relief at that 2-hour mark. About double that amount of patients, so almost 40% of patients were free from their most bothersome symptom at that mark. So that is exciting. And these don't have the same issues. If you did have a stroke in the past, if you have really high blood pressure, if you had issues with triptans, these work completely differently. So they are a really exciting option for a lot of patients. So the question that we get a lot, and the question that we had initially, first off, was, can you use one of these new abortive CGRPs with one of the preventive options that we already have? So if you were already on Emgality, can you also now use Ubrelvy when you have a headache, and is it going to work? And the answer is yes. So luckily we have some good data on this. So Nurtec actually did allow use of the preventive CGRPs, the injections, during the trial that got Nurtec approved. And there was a report that was released that provided info on 2 patients that were on Aimovig for prevention and then took Nurtec for abortive treatment. And during the period when they were on both, their migraines that did come up were relieved by the Nurtec. And so that was really great. We can't take this, completely to heart because there was only 2 patients. We need way more patients to really generalize to say this is definitely going to work for you. And the fact that all of their acute headaches were relieved by the Nurtec is actually higher than we would think we would see based on the trials that got it approved. So we definitely want more data, but we do feel like it's appropriate for sure to be using both of them together. If you take a look at the science and like the hypothesis behind whether or how these kind of work together, the small molecules, so the abortive treatments are small molecules. That's why you can take them orally instead of injecting them. It's thought that maybe because they're so small, they're able to get in and access a different pool of receptors than those large molecules are. Generally, just a tidbit. So large molecules generally have to be in IV or injectable forms because they're not able to get small enough to be in an oral tablet. But small molecules are given orally. And it's thought that the small molecule may also provide an enhanced inhibition via some different cascades inside the cell. Again, just getting in somewhere that maybe the large molecule can't. So in summary, we can use both of them at the same time with good effect. There's no safety concerns by targeting CGRP in both ways. But we don't have long-term studies and we don't have big studies. So more time to tell, and we need more patient data. We also had some other new migraine abortive treatments that were approved. One is Celicib, which some of you may recognize that name, or its brand name that we know it as is Celebrex. They actually reformulated this into a migraine treatment. And then lasmiditan, or Rayvow. So lasmiditan is actually approved in 2019, but I thought it was important just to make sure that everyone was aware of this one as well. It also has a different mechanism than the triptans. It is a controlled substance, so it does have more restrictions on it with regard to the prescription, with regard to the number of refills, and in the way that it's tracked. It was given this distinction because of studies that took a look at how it impaired driving and things like that. So for that reason, there's no driving with the Rayvow for 8 hours. In people that use it, they essentially use it at night when they're planning on going to sleep for at least 8 hours. But you can, the dosing is 50 all the way to 200 milligrams, and you should only be taking one dose every 24 hours. Again, when you are planning to be home for 8 hours, or at least having someone else drive you somewhere, because driving was impaired in simulated driving tests that they had patients do. There are more side effects with the Rayvow than there are with our other two new abortive treatments, such as dizziness, fatigue or tiredness, paresthesias, which are like if you've ever felt like tingling in your fingertips, or after your arm has fallen asleep and it's coming back to life, those tingles are paresthesias. Nausea and vomiting, muscle weakness were seen. And it can decrease the heart rate and increase blood pressure a little bit for 1 to 2 hours right after you take the dose. And most of these adverse effects were what's known as dose dependent. So a lower dose would have more mild side effects, and the more side effects are seen as you increase the dose. So we did see good efficacy here. At the highest dose, about almost 40% of patients were pain-free at 2 hours, and at the lowest dose, about 30% of patients, and about 40%, maybe up to 50% at that highest dose, were free from their most bothersome symptom at that 2-hour time point. So again, we have an option for patients who cannot tolerate triptans for whatever reason. This one does come with a few more side effects to consider and a few more restrictions with regard to it being a controlled substance. But it's definitely great to have a new option. And because not all abortive treatments will work for everyone, it's good that we have a couple new options that have different mechanisms. So if you try Ubravi or Nurtech, they don't work for you, there's this other option as well. So Celicib oral solution, its brand name is Celicib. So again, like I mentioned, Celicib has been around for a long time under the brand name Celebrex as just a pill for pain relief. And this is a oral solution that's a single dose that's formulated for specifically for migraine. It did have pain freedom of about 35.6% of patients, so almost 40% pain-free at 2 hours versus 20% on placebo. So there may have been a fair amount of placebo effect in this trial, or patients who had the feeling of migraine relief even when they didn't have any medication. And almost 60% of patients were free from their most bothersome symptom at 2 hours. But again, the placebo rate was high here as well. So Celicib, how it works is that it's a non-steroidal anti-inflammatory drug. So other NSAIDs are ibuprofen, naproxen, so brand names like Advil or Aleve, those are all NSAIDs as well. Celicib, though, is a COX-2 selective NSAID versus the other medications that we get over the counter are not selective. Now, this selectivity, the main issues that there are with NSAIDs, the big issues are GI adverse effects, so gastrointestinal adverse effects, including bleeding. So if you take NSAIDs too much, like if you're taking ibuprofen at a high dose multiple times a day, every day, it can wear out your stomach lining, cause stomach ulcers, and lead to bleeds, which can be very severe. Use of NSAIDs can also contribute to increased risk of cardiovascular events like heart attack and stroke. And so having this selectivity may result in a decreased risk of the GI aspect of the adverse effects, but it may increase the risk of those cardiovascular adverse events. And so it's kind of a wash there, but it is another option for patients. I wanted to talk a little bit about access to new medications because there are definitely more hurdles to getting new medications than there are getting older established medications. New medications are definitely more expensive, always more expensive. So these hurdles are so insurance companies essentially cut their costs wherever possible and make sure that patients are getting therapies that are evidence-driven and are fit to them. So some of the things that insurance has put in place, one way is called step therapy. So we're seeing this with the Vyepti, the new IV form of the CGRP, the preventive. So a lot of insurance companies are saying you need to try one of the at-home injectable CGRP options, one or two or three of them, prior to us covering the IV formulation. Because even though those at-home injectables are expensive, the IV form is even more expensive. We also see prior authorizations with a lot of new medications, and those prior authorizations are sometimes we need to prove that you've tried those other therapies in the past. Sometimes we need to prove that you're not a candidate for a triptan, so you need to use Nurtec or Ubravi or Rayval, something like that. It's often proving medical necessity. And sometimes insurance companies, and they can choose to do this, they can just choose to not put these drugs on their formulary, which means that you're not going to have access to those certain drugs. So this happens a lot when there are multiple medications that work the same way. So a lot of insurance companies may say, I'm going to cover Nurtec for specific patients, but I'm not going to cover Ubrelvy at all. I'm just going to focus on Nurtec because they work the same way. They have similar efficacy, similar side effects. There's no reason that I need to be covering both of them. Now, to help with coverage, copay cards are available. Copay cards come directly from the manufacturer of the drug. They are drug specific, and they're a way for patients to try new drugs in an affordable way. The drawback of copay cards is that they're available for patients with commercial or private insurance, but they're not able to be used by anyone with government insurance. So any Medicare plan, even if it's a Medicare Advantage plan, or any type of Medicaid, you would not be able to use a copay card. Now, if your insurance completely doesn't cover the medication, or if you don't have insurance at all, manufacturers often also have patient assistance programs that may be available to offer the drug at no cost. This is drug specific. It's not available for all drugs, and there's often a lot of eligibility requirements with regard to income limits, the amount that you may have spent on your medications in the past year, and proving that you don't. Proving sometimes your income, and for lack of coverage, proving that your insurance doesn't cover it. So those are just some things to keep in mind, especially if you're interested in new medication, and it can be really frustrating when you don't have access to new and exciting therapies. So with that, I will end kind of the formal presentation portion, and we can have any discussion.